When we receive more questions, I'll
You want to give them? You want to give them written?
not necessary. If in case I receive more such questions, in case of any question that you're not able to sort of answer, if you've not reviewed the guidelines or something of that sort, you can always say that you'll get back to us, and you can share the answers in written, and then I can share it on the platform. That can also be done. Okay, so we'll start out. Hello and a very good afternoon to all our viewers. Welcome to the Wednesday Master Series session with our expert. We would like to welcome audience from all over the world, but especially from India and the Middle East. Our speaker for today is Dr. Perele Adnan Hajjon. Dr. Hajj is a leading endocrinologist and has been practicing at St. Joseph Hospital in Beirut, Lebanon, and at the military hospital Sarwa since the past 10 years. She holds an acted in endocrinology and metabolism accredited to Paris Descartes 2010. She has been a lecturer at the Lebanese University for 2 years and also a representative for many multinational and national pharmaceutical companies. Dr. Hajj was very kind to accept our invitation for sharing her insights on the updates of standards of medical care in diabetes. So welcome, Dr. Hajj, to DocPlex's online medical platform, which is India's largest growing community of medical professionals. Over to you, ma'am.
Thank you, Darshika, and welcome everyone. I'm glad to share with you the new guidelines, the updates on the standards of medical care in diabetes. And can you see my screen?
Yes, ma'am. Please go ahead.
I can't. Okay. So these are my disclosures and references. I have no relevant financial or non-financial relationships to disclose. And my references will be mainly the American Diabetes Association Guidelines 2022, the National Institute of Health and Care Excellence NICE Guidelines 2022, and the International Diabetes Federation. So, as you all know, diabetes is a pandemic of unprecedented magnitude now. It's affecting 1 in 10 adults worldwide. And these numbers are going to increase. So now we have 570 million people with diabetes living on the globe, and the percentage of prevalence of diabetes will increase, is expected to be increased in 2045. And look where the areas the increase will be more. It will be at the South Central America, 50% increase, Africa, 134% increase in prevalence, the MENA region, 87%, and Southeast Asia increase of prevalence by 68%. So huge number of diabetic patients will be living on the globe. So diabetes will never, and the macrovascular complications like retinopathy, nephropathy, neuropathy, and increased risk of cardiovascular complications such as coronary heart disease and stroke. And these complications often come with a significant cost. So this study in the UK was done on annual cost of hospital treatment. And as you can see here in green, you have the increase, the amount of cost in patients, in diabetic patients with 4 or more complications as compared to patients, diabetic patients without complications. So you have 12 times more increase in annual cost of hospitalization for those patients. So the science of diabetes care is continuing to evolve, and the updates this year, they focus on screening, preventing complications, use of technology, individualizing diabetes care, and new recommendations are done concerning the first-line drug treatment. So, for the screening and diagnosing of diabetes mellitus, you have all those criteria. So you have to test every obese patient or overweight patient with one or more of the following risk factors, like if he has a family history of diabetes, a high risk ethnicity, if he has cardiovascular disease, hypertension, dyslipidemia. You have to screen women with a polycystic ovary disease if they are obese. And only if they are obese and with physical inactivity, also you have to screen them. So, and patients with prediabetes have to be tested every year. And women who were diagnosed with gestational diabetes should have lifelong testing at least every 3 years. And what's new is here in the number 4. It used to be screen all patients when they have at the age of 45 years, and now it is becoming begin testing all patients at age of 35 years old. So this is new. And what's also new in screening for diabetes in pregnancy, the recommendation to screen for gestational diabetes between 24 and 28 weeks has not changed. But what's new is you have to screen all women who are planning to become pregnant, especially if they have risk factors. And for unplanned pregnancies, women should be screened at the first prenatal visit. What about children and adolescents? You have to screen children and young people that have high BMI, more than 85th percentile, and one or more risk factors. If they have family history of type 2 diabetes in first or second degree relative, if they are of a high risk ethnicity, maternal history of diabetes or gestational diabetes, and signs of insulin resistance or conditions that are associated with the insulin resistance, like the acanthosis nigricans, hypertension, dyslipidemia, PCOS, or small for gestational age babies. So why we screen? This is to prevent or delay type 2 diabetes and the associated comorbidities. So you start by a lifestyle behavior change for diabetes prevention for all of those pre-diabetic patients. Then for the pharmacologic interventions, we still have only metformin that is approved, and it should be considered in pre-diabetic patients, especially if they are young, between 25 and 59 years old, with high BMI, more than 35, and high fasting blood sugar, more than 110 milligrams per deciliter, and high A1C, like more than 6%, and in women with prior gestational diabetes mellitus. You have also, for those patients, to prevent the vascular disease and mortality. So what you have to do is look at the other comorbidities. So if they have hypertension, if they have dyslipidemia, you should treat all these. If they smoke, you should encourage them to stop smoking. So you have to use a patient-centered care goals. For the diagnosis of prediabetes and diabetes, we have nothing new to say. Always an A1C that is less than 5% and fasting blood sugar of less than 100, with an oral glucose tolerance test when you give 75 grams of sugar and you examine the glycemia after 2 hours, it would be less than 140 milligrams per deciliter. This is for normal people. Pre-diabetic patients is when you have an OGTT, which is between 140 and 200 milligrams per deciliter, a fasting blood sugar between 100 and 126, and an A1C between 5.7 and 6.5%. Diabetes is defined by an oral glucose tolerance test that is superior to 200 milligrams per deciliter, a fasting plasma glucose of more than or equal to 126 milligrams per deciliter, and an A1C that is equal or more than 6.5%. So after diagnosing your patients, you have to individualize your care of the patient with type 2 diabetes, and this is demanded by all the guidelines, NICE and the ADA. So you have to take into account personal preferences, comorbidities, and risks from polypharmacy. You have to reassess the person's needs and circumstances at each review and think about whether to stop any medicines that are not effective or are doing harm. Take into account any disabilities, including visual impairments, like, for example, when planning and delivering care for adults with type 2 diabetes. So, a patient-centered approach is demanded to improve medication adherence and management, and you should review also social and financial barriers of patients. So, what are the targets for glucose nowadays? Also, you have to individualize the targets in each and every patient. So, if you have a young patient with no important comorbidities, like no established vascular complications, and it's a newly diagnosed diabetes, of course, go for a less than A1C of 7%. And if you have a patient that is elderly with a short life expectancy and important comorbidities, you go less stringent in your glycemic goals. So mainly an A1C of less than 7% is good, acceptable, and go lower for A1C because they say it's acceptable and even beneficial if it can be achieved without significant hypoglycemia or other adverse effects of treatment. And you can go with the higher goals, less than 8%, for patients with limited life expectancy or where the harms of treatment are greater than the benefits, especially in frail patients and chronic kidney disease patients. We have now a new glycemic goals, which is the time and range goals. So if you are using a continuous glucose monitoring indicator, you have to have a time and range that is superior to 70%, time below range that is less than 4%, and time and severe hypoglycemia less than 54 milligrams per deciliter of less than 100%. So, continuous glucose monitoring with the advance with the advent of new technologies, you have the CGM. They have evolved and they are becoming. They evolved rapidly, and they are more accurate and more accessible nowadays. So they are included now in many guidelines. So glucose assessment by CGM is included in the ADA guidelines, and they say that standardized single-page glucose reports from CGM devices with visual cues, such as the ambulatory glucose profile, should be considered as standard summary for all CGM devices. So they are requesting a standardized profile of the CGM. So they created what we call time and range, because time and range was associated with the risk of microvascular complications and it can be used for assessment of glycemic control. Time below target and time above target are useful parameters for the evaluation of the treatment regimen. What I'm saying is this. This is an example of what we now say a report from a continuous glucose monitoring should be. So if you look down, you can see a CGM of 14 days, and in the middle you have like a summary of those 14 days with a target range between 70 and 180, and you see the time in range, the percentage of time those people stage or this patient stayed in range, in the target range, all over those 14 days. And also you can see the time below range, and you can see also here the glucose matrix, the average glucose, it is mentioned, and the glucose management indicator here for this patient is of 7.5%, and this reflects also what an HbA1c could be for this patient. So it's an HbA1c equivalent, we can say, and the percentage of glucose variability. So what they are asking us to do is to have a target enrich time that is more than 70%, because this will be indicating or will be equivalent to an HbA1c of 7%. So it is in all guidelines now, the NICE guidelines for CGM. All adults with type 1 diabetes should have access to either flash or CGM. All children with type 1 diabetes should have access to CGM. And patients with type 2 diabetes who use insulin-intensive therapy, two or more injections a day, should have access to flash only if they have recurrent or severe hypos, and if they have a disability, they cannot finger prick test, or if they are advised to test 8 or more times a day. So practically, all type 1 diabetic patients in the NICE guidelines should be used or should have access to CGM, and type 2 diabetic patients on complex insulin regimen with some difficulties also, they can have the CGM. What about the ADA guidelines for CGM? So in the last year, ADA guidelines was used to use CGM for people who take only rapid acting insulin, but this year they added people who take only basal insulin, they can go and have CGM, and also they accept to use CGM in hospitalized patients if the patient can or know how to monitor this CGM safely. And this was created after the COVID-19 era, where they thought that this CGM in hospital, it can decrease the contamination between patients. So the 2022 guidelines also expand recommendations for diabetes technology use among all children with type 1 and type 2 diabetes who are on rapid acting insulin. So practically for the ADA, every patient taking insulin is eligible to have a CGM. So also in their recommendations, you have the training of patients and caregivers and technologies. So caregivers should be helping patients to select devices, and both should be given ongoing training and education and being evaluated on their skills in using the devices and the data from those devices. People using CGM devices must always have access to blood glucose monitoring devices, which are often more accurate devices but require a finger prick. So we still need the devices, blood glucose monitoring devices with finger prick to adjust our treatment. And now we have this trend to a comprehensive medical evaluation and assessment of comorbidities. So a comprehensive medical evaluation should be done for each patient. The goal of our care should be to prevent complications in this patient and optimize the quality of life for this patient. So you should, what should be done is a comprehensive medical evaluation from the first initial visit. So in the first initial visit, complete medical evaluation should be performed. You confirm the diagnosis of diabetes and classify the diabetes, then evaluate for the complications and receive previous treatment and also risk factors control, begin patient engagement in the familiarization and the formulation of a care management plan and develop a plan for continuing care. So this is how we start. We assess the assessment and treatment plan. You assess for diabetes complications. So you assess for cardiovascular risk, for heart failure, for chronic kidney disease. Of course, you assess for hypoglycemia, retinopathy, and nephropathy. Then you set the goal, set an HbA1c goal or time in range target for each and every patient. And if you have comorbidities like hypertension, dyslipidemia, you have to treat. And then also you have to teach diabetes self-management. So if you have a patient who comes to you and you don't explain to him what should be his fasting blood sugar or 2 hours postprandial blood sugar, and you ask him to monitor, he will not be engaged in his treatment. So, and the therapeutic treatment plans, you have to talk about lifestyle management and pharmacotherapy. And the pharmacotherapy, you have to think of glucose lowering, of course, but of course also nowadays you have to consider pharmacologic therapy for cardiovascular and renal disease risk factors. So use of glucose monitoring and insulin delivery devices, and referral to diabetes education and medical specialists as needed. So monitoring patients' cognitive capacity or impairment. Nowadays, we have a new section about the importance of monitoring patients' cognitive capacity or impairment, and this is in the ADA. And we should be referring patients for formal assessment if needed, especially children, patients with hypoglycemia, and older patients. And changes in a patient's cognitive capacity or signs of cognitive impairment can increase the risk of hypoglycemia. And severe hypoglycemia increases the risk of dementia. So assess for hypoglycemic risk. Of course, in patients who are using insulin or SUs, in patients who have impaired kidney functions or hepatic function, longer duration of diabetes, frailty and older age, cognitive impairment, alcohol abuse, etc. So they stress on improving hypoglycemic awareness. And this is to say that hypoglycemia unawareness or hypoglycemia associated autonomic failure is described as an urgent medical issue in patients with type 1 and patients with type 2 with severe insulin deficiency. What is this? This is when you have your patient having a repetitive hypoglycemia and he becomes incapable of perceiving the symptoms of hypoglycemia. So the threshold for developing symptoms of hypoglycemia will become lower. So it is an urgent medical issue. And at this time, the new standards of care highlights evidence showing that relaxing glucose targets for a few weeks can improve hypoglycemia awareness in many patients. So if you have a patient like this, stop being pushy and stringent uh, in your goals of glycemia. You can allow a higher glycemic uh, goals for few weeks, just for the patient to be aware of his symptoms again. What else, and this is not surprising, after the COVID-19 era, people who work with diabetic patients are now, they encourage vaccination. And the importance of routine vaccinations for people living with diabetes has been elevated by the COVID-19 pandemic, especially in obese patients also. So, and they say that preventing avoidable infections not only directly prevents morbidity, but also reduces hospitalizations, which may additionally reduce risk of acquiring infections such as COVID-19. So, children and adults with diabetes should receive vaccinations according to age-appropriate recommendations. And I'm not only talking about COVID-19 vaccine, but also about flu vaccine for the adult patients. So we cannot talk diabetes without talking obesity and weight management for the treatment of two diabetic patients. So many of our diabetic patients are obese now, and this is a disease in itself. And we have to care for patients with overweight or obesity. And we should enroll them in a lifestyle behavior change program to prevent diabetes and its complication. They should receive guidance on healthy meal planning based on both food quantity and nutrition levels. And the recommendations emphasize the importance on food quality over quantity. So manage glucose through more than just carbohydrate counting. Regardless of the amount of carbohydrate in the meal plan, people should focus on eating high quality and nutrient dense carbohydrate sources that are high in fiber. So both children and adults should limit the amount of refined and processed carbs they eat that include added sugars, fat, and salt, and instead they have to focus on getting their carbs from vegetables, legumes, fruits, dairy, and whole grains. And also, there was a new guidelines or new medicines approved by the FDA for managing obesity, such as an oral hydrogel or semaglutide, higher doses than that we know, 3 milligrams. So, what are the treatment options for overweight and obesity in type 2 diabetes? So, how to start treating? So, diet, physical activity, and behavioral counseling for all categories of BMI, and pharmacotherapy for the BMI category patients with BMI of 27 to 30, and only consider metabolic surgery for patients with a BMI of more than 30. So what are the medications that are approved now by the FDA for the treatment of obesity on adults? You have the phentermine as a short-term treatment, so less than 12 weeks. And for the long-term treatment, we have the orlistat, phentermine topiramate, naltrexone, bupropion, liraglutide, and semaglutide. So what about the initial treatment of type 2 diabetes? As you can see, these are the nice guidelines 2022. NICE guidelines, they want us to continue treating the first line treatment to be metformin. But what they added this year is they assess cardiovascular risk and kidney function in their patients from the beginning, and they see if the patient is not at high risk of cardiovascular disease. So first choice is metformin, and if metformin is contraindicated, you can see, go to the left side of the of your screen, and you can see what are the other eligible medicines: DPP-4 inhibitors, pioglitazone, sulfonylureas, and SGLT2 inhibitors for some people. So not all patients are eligible for SGLT2 inhibitors as a first choice. But if your patient is or have chronic heart failure or established atherosclerotic cardiovascular disease, or is at high risk of developing cardiovascular disease, at this time, metformin is the first choice, and you can add SGLT2 inhibitor with proven cardiovascular benefit. So this is for the NICE guidelines. So what was new, they are still having metformin as first-line drug, and they insist on this. And second, they assess person's cardiovascular status, and based on the cardiovascular risk assessment, if they have chronic heart failure or are at risk for developing cardiovascular disease, they consider adding SGLT2 inhibitor with proven cardiovascular benefit in addition to metformin. So this was the NICE guidelines, and for the ADA guidelines, they are going more flexible now. I know it's a big, it's a complicated diagram, but look at the first here. Now they are more flexible. I'll go. This is what they say. The first line therapy depends on comorbidities. So patient-centered treatment factors and management needs generally includes metformin and comprehensive lifestyle modifications. So generally, the first line therapy is metformin and comprehensive lifestyle modification, but other medications like GLP-1 receptor agonist and SGLT2 inhibitors with or without metformin based on glycemic needs, they are now being appropriate initial treatment for individuals with type 2 diabetes with or at high risk for atherosclerotic cardiovascular disease, heart failure, and or chronic kidney disease. So I'll go back to this and explain even more. They stratify the patients from the beginning. If your patient is a high-risk patient for cardiovascular disease or heart failure or chronic kidney disease, from the beginning, you can start by either GLP-1 analog or SGLT2 inhibitor instead of metformin or in addition to metformin. So they are more flexible. They give you the choice. Then the second choice would be also if you have, you stratify your patients, either if you have a high-risk patient for heart failure, coronary artery disease, or heart failure, and you go with SGLT2, GLP-1 analog. I'll not go through this, but also if you have a patient without comorbidity, without risk factor for cardiovascular disease, you have to think of a drug that minimize hypoglycemia and minimize weight gain or promote weight loss. And also you have to consider cost and access. Okay, so in some countries you don't have SGLT2 inhibitors, or you have them very expensive. You don't have GLP-1 analogs, or we have them very expensive. So consider this, because what counts is our patient and our patient being able to take his medical treatment to the treatment to continue. Okay, again, cardiovascular and kidney disease are the biggest contributors to morbidity and mortality in patients with type 2 diabetes. So, as in the study, patients with type 2 diabetes have twice the risk of cardiovascular disease compared with the general population. And chronic kidney disease is estimated to affect almost 40% of patients with type 2 globally. So reducing the risk of cardiovascular and renal complications is an important treatment goal in type 2 diabetes. So we have now what we call a four-pillar approach created by the ADA this year. So it's a comprehensive approach to the reduction in the risk of diabetes-related complication is now recommended. So therapy that includes multiple concurrent evidence-based approaches to care will provide complementary reductions in your risk of microvascular, kidney, neurologic, and cardiovascular complications. So now we have management of glycemia, blood pressure, lipids, and the fourth pillar is the incorporation of specific therapies with cardiovascular and kidney outcomes benefit. They are considered fundamental elements now of global risk reduction in diabetes. This is what it looks like. So lifestyle modification and diabetes education is at the base of every treatment, and you have the four pillars: glycemic management, blood pressure management, lipid management, and the agents with cardiovascular and kidney benefits are very important to be considered to reduce the diabetes complications. So SGLT2 inhibitors now are recommended to treat heart failure and can be started at the time of diagnosis, as we started to say with the ADA guidelines. They are now safe to use in stage 4 chronic kidney disease. You have the finerenone, a recently approved non-steroidal MRA drug. It can alternatively be used to improve both kidney and heart outcomes if SGLT2 inhibitors are not efficient. And combination therapy may be considered for people with established heart or kidney disease. So if you are already not a new patient, but as a second or third line treatment, if you have insulin, you can add LP1 analog. And if you have either LP1 or SGLT2, they can both be added or added from the beginning. So with this, I come to my summary. Diabetes is a highly prevalent disease with several complications and significant cost. Start screening all adults for diabetes and prediabetes starting the age of 35-year-old. Individualize the diabetes care for every patient. So assess the risk of complications, set a goal, and have a therapeutic treatment plan. Use technologies, new technologies like CGM are now integrated in the guidelines for diabetes management. And don't forget to vaccinate your diabetic patients for the COVID and flu. And remember the four-pillar approach, a comprehensive approach to the reduction in the risk of diabetes-related complications is recommended now. So not only glycemia, but also lipid, hypertension, and agents with cardiovascular and kidney benefit. And SGLT2 inhibitors and GLP-1 analogs are upgraded now to first choice in patients with cardiovascular disease, heart failure, and chronic kidney disease. I hope I covered mainly the main updated guidelines. And with this, I thank you everyone for your presence, and I'm glad to hear your questions.
Thank you so much, Dr. Hajj. It was a brilliant presentation. You very beautifully summarized the entire guidelines. We've received a couple of questions from the audience, so we'll take those one by one. My first question is from Dr. Subramanian, who says, up to what level of EGFR serum creatinine can continue metformin in DKD?
We can continue using metformin up to EGFR of 30 milliliters per minute.
Okay.
30 milliliters per minute.
Okay. Sure.
And below this, you know, we have many studies that show beneficial or unharmful effect of metformin, but in the guidelines, we still use 30 milliliters per minute as a cutoff.
Okay, sure. Thank you so much. I hope Dr. Subramanian got his answer. My next question is from Dr. Jaydeep Nanda, who says, what is the drug of choice when it comes to gestational diabetes patient?
Of course, it's insulin. You can start with. Listen, you want the guidelines? It's insulin. If you want off guidelines, and many studies they showed that you can, if a patient was already started on metformin, you can continue using metformin and add insulin if this is needed.
Okay, sure. But in the guidelines, it says insulin, right?
Yes.
Okay. My next question is, so this is about automated decision support systems. So the doctor says, are automated decision support systems useful in managing type 2 diabetes mellitus?
I think yes, especially when it comes to the variability, inpatient variability of the glycemia during the day. For example, you can have a patient with two patients with HbA1c of 7%. One of them is having severe hypo and hyperglycemia with a mean A1c of 7%. This patient is not living well and is not having a well-controlled diabetes. I can tell, because hypo and hyperglycemia is harmful to this patient. If you have the other patient with an HbA1c of 7%, with, like I've said, a time in range that is more than 70%, this is a patient that is being well controlled with very low hypoglycemia or severe hypoglycemic events. So yes, I think it is useful and it will be the future. This is why they included it in many guidelines. I know in some countries like mine, it's still not widely available, and it's still not cost effective, because it's so you can still use HbA1c. This is a standard, but I guess the future will come, and these CGM will be the future.
Okay, sure. Thank you.
And treatment in diabetes, I want to say.
My next question is from Dr. Swapan Sarkar, who says, I think you did talk about time in range. So what is time in range and how can it help in controlling diabetes?
So yes, as I've said, time in range is the percentage of time this patient, our patient, stayed in range that we told him to stay. The percentage of time he stayed in range, in what you define a normal range.
Okay.
And what is below range. So in hypoglycemia, how many times he stayed in hypoglycemia or severe hypoglycemia, or in hyperglycemia. So you can have an idea about your patient being well managed, or the what you prescribed for him is being well.
Okay, I got it. Also, one last question, ma'am. So, which agent can be used for treatment of microalbuminuria in preconception period in diabetes? It's from Dr. Yatla.
Preconception period in diabetes.
Yeah.
I guess in the in preconception area, you have to stop all the because when you get pregnant, you cannot take any of those medications. They are not approved yet. But in the preconception, you can take everything. SGLT2 inhibitor with proven CKD risk reduction. You can use ACE inhibitors, ARBs. You can use all of these. But when the patient get pregnant, you have to stop all these.
Yeah. Okay. Let's check for any more questions. I think one of the questions is also on what are the recent advances in management of diabetes. I think you've already covered that in the talk. So, ma'am, these were all the questions we had. And I think towards the end of the session, I would like to thank you for taking out time and about delivering this wonderful lecture for our Indian and Middle Eastern audience. So, hoping to see you soon, very soon again. Ma'am, any closing remarks or closing statements for today for our audience who's watching us here?
Just a big thanks for everyone who attended, and I hope I added something new to our audience.
Okay, sure, ma'am. Thank you so much, and it was wonderful having you here. So, dear audience, if you have any more questions, please write answer them, and please follow us and for any such clinically enriching sessions, do watch it on exclusively on DocTexas. So have a great evening ahead. Thank you so much. Thank you so much, ma'am.
Thank you.
Ma'am, if you could just stay.